Good evening, sir.
Good evening, Anisha.
Shall we start, sir?
Yeah, good evening to all the postgraduates.
Good evening, sir. Good evening, sir.
How many of you are there?
3 of us, sir. We 3 of us are here, sir.
Fine. You have started video recording now, Anisha?
Yes, sir. They have started, sir.
Just a message came that recording is on.
Yes, sir.
Okay, very good. Okay. Three. So who are presenting today's case?
Sir, myself, my name is Dr. Madhubalan. I'm final year PG from Satyasai Medical College.
Where are you from?
I'm from Chennai, sir. My birthplace and my hometown is. I'm from Chennai, but my hometown is Tanjore, sir.
Hometown is Tanjore. So Tanjore is famous for?
Tanjore Periya Koil is there, sir.
Yes.
Temple is there.
Yes, other than that?
Sir?
Other than that?
It's known for cultivation, wheat cultivation, rice.
Okay. The other postgraduate?
So I'm Annie. I'm also final year PG, sir.
Okay. Where are you from?
I'm from Chennai only, sir.
Native of Chennai.
Yes, sir.
Okay, what are the new things in Chennai that if I come, I can look at?
New things, sir. Nothing new. It's just the same old mall, same old sightseeing. That's all, sir. Beach, that's it.
Okay, fine. Who is the other PG?
Good evening, sir. I'm Neelam. I'm from Maharashtra, sir. I'm second year postgraduate.
Okay, from Maharashtra, you landed here?
So, need PG counseling, sir. All India counseling. I got it here, sir.
Okay. Yeah, nice to hear. Yeah, shall we start then?
Yes, sir.
Yes, sir.
Yes, sir.
Yeah, you can start presenting the case.
Yes. Sir, are you able to see the presentation, sir?
Yeah, I can see.
Okay, sir. So today we're doing a long case presentation on thyroid, on a thyroid case. Presented by me, Annie, Madhubalan.
No. See, nothing to worry about what you are going to present.
Yes, sir.
We are all learning.
Yes, sir.
Yes, sir.
So, whenever you have any doubts, don't hesitate to learn. Okay?
Okay, sir.
Yes, sir.
Yes, sir.
Please, yeah. Yeah, start the presentation.
Yes, sir. This one, can you move it first?
Return to work, please.
So I'll start the presentation. Sorry, sir.
Yes, please.
A 55-year-old female patient, Mrs. Sarita, who is a housewife coming from Tirupurur, came with the chief complaints of swelling in front of the neck for the past 4 years. History of presenting illness. The patient was apparently normal before 4 years, after which she noticed a swelling on the anterior aspect of neck, which was insidious in onset, gradually progressive in nature, attaining the current size, not associated with pain. She had history of weight loss over a period of 6 months, gradually decreasing in weight around 2 kg per month. She had history of increased appetite, history of increased sweating, history of hand tremors, history of palpitations for a period of 3 months, history of difficulty in swallowing plus for a period of 1 month, mainly for solids, history of difficulty in breathing in lying down position for the past 3 months, and history of snoring.
Okay.
There was no history of any other swelling, no history of fever, no history of hoarseness of voice, no history of Horner's syndrome, no history of syncope, no history of insomnia or sleep disturbances, no history of diarrhea, constipation, no history of muscle pain or weakness, no history of cold intolerance, no history of easy fatigability, no history of sudden increase in size of swelling, no history of bone pain, no history of jaundice, no history of cough with hemoptysis, no history of headache, convulsions, or seizures.
Yeah.
Past history, patient is a known case of hyperthyroidism for the past 4 years under treatment with tablet carbimazole 5 mg BD and tablet propranolol 40 mg BD. Not a known case of diabetes, hypertension, asthma, epilepsy, tuberculosis, jaundice, ischemic heart disease. No history of irradiation. No history of previous surgery. No history of any other drug intake. Personal history, mixed diet, no adverse social habits, has disturbed sleep pattern, normal bowel and bladder habits. Menstrual history, attained menarche at the age of 15 years, normal flow, regular cycles, not associated with pain or clots. A case of P2L2, last childbirth 25 years ago, attained menopause 10 years ago at the age of 45. Family history, no history of similar complaints in the family. Allergic history, no significant allergic history.
Okay.
Okay.
From the history, what is your provisional diagnosis?
Sir, she's a female, 55-year-old female, and with complaints of weight loss and tremors and palpitation present. So it shows signs of hyperthyroidism and signs of hypo such as cold intolerance and weight gain. Those things were in negative history. And,
there is also pressure symptoms present, sir, in her history. So there might be a possible retrosternal extension of the thyroid or the goiter.
Okay.
So
Okay,
that's
Yes, sir.
Yes, sir.
Okay. Now you have asked so many questions to her. There were some positive findings, there were negative findings.
Yes, sir.
Instead of me asking every time the question, right from the age, you asked for age, right?
Yes, sir.
Well, why did you ask that question?
So age signifies some occurrence, incidence of diseases. For example, goiter usually occurs between 30 to 50 years of age. Malignancy occurs in older people. Graves' disease in relatively younger people between 20 to 40 years of age.
And goiters between middle-aged women, 50 years of old, and our patient is around 55 years of age, sir.
Okay, then what about the sex of the patient?
Female patients. Predominantly, goiters are more common in hyperthyroidism, more common in female patients, sir. So, Graves' disease, the ratio is almost 1:5 for male is to female, sir.
Okay, what else you asked? Next question.
Sir, low socioeconomic status, sir. It shows that iodine deficiency might be there, which might lead to 3SH synthesis in deficiency, which might be the cause for this condition, sir, hyperthyroidism.
Okay, what else?
Also the location of the patient, iodine deficiency in hilly areas.
Okay, good. That is about the basic demographic profile you had asked, right?
Yes, sir.
Then the next questions that followed were to look at the pathophysiology of thyroid disease.
Yes, sir.
And in that sense, you wanted to rule out the compression symptoms.
Yes, sir. Yes, sir.
So compression symptoms means where are all the compressions?
So the compression can be over the trachea or esophagus, sir.
What else?
Compressions around surrounding blood vessels, sir.
Basically, initially, just if you go back to the history.
Yes, sir.
See here, you asked for compression symptoms.
Yes,
one
sir.
is esophagus. You asked for
difficulty in swallowing, sir.
Yes. Then difficulty in breathing for compression or trachea. Correct?
Yes, sir. Yes,
Yes,
sir.
sir.
Yes, sir.
Then he asked one more question with regard to involvement of your recurrent engine now, right?
Hoarseness
Or-
of voice, sir.
Hoarseness of voice.
So that is also involvement of the now. You wanted to
Yes,
rule
sir.
out, correct?
Yes,
Yes,
sir.
sir.
So that is about the compression symptoms you wanted to rule out.
Yes,
Yes,
sir.
sir.
Then you wanted to rule out hyper and hypo futures, correct?
Yes, sir. Yes, sir.
So hyper and hypo futures, can you just enumerate?
So hyper features will be sleep disturbances, diarrhea, constipation, heat intolerance, muscle pain or weakness, and easy fatigability, sir. Palpitations, tremors. These are hyper symptoms, sir.
For hypothyroidism, insomnia and
Cold
cold
intolerance.
intolerance.
Again, easy fatigability.
Easy fatigability will be there.
Bradycardia might also be there, sir.
For
Cold extremities. Then there will be some hair or skin changes will be there. In case of hyper, the patient might present with alopecia, brittle hair. And in
Okay.
case of skin in hypo, there might be dry skin presentation and alopecia there as well. The lateral part of eyebrows may be missing, sir.
Okay. Now this case, any features?
This case, patient has some hyperthyroid features, sir. Like she has increased sweating.
Hand tremors.
And hand tremors are there. Palpitations was there for the patient. Also weight loss.
In spite of
increased appetite, sir.
So this now, do you say that is a primary or secondary thyrotoxicosis features?
Sorry, sir?
Primary and secondary thyrotoxicosis features.
This will be primary, sir.
It looks like primary thyrotoxicosis features.
Is CNS involvement or CVS involvement?
Sorry, sir. This is mostly secondary thyrotoxicosis because primary toxicosis will have more of CNS symptoms, while secondary toxicosis we will have more of CVS symptoms, sir.
Yeah. But then you asked for something about fever association with swelling, right?
Yes, sir.
Why did you ask for that?
Sir, it could be an infected swelling in the midline also.
Different.
To
differentiate different types of swelling from
midline swelling,
sir.
No, fever. Fever basically to rule out any thyroiditis or something.
Yes, sir. Thyroiditis. Yes, sir.
Inflammation.
Okay, then about swelling size, how gradually it has increased, you asked for, right?
Yes, sir.
Yes, sir.
Why did you ask for that?
Sir, if there was a sudden increase in the size of the swelling, it could attribute to features of malignancy.
And if this patient has an insidious and progressive type of swelling.
Usually long-standing progressive increase in size will be symptomatic of goiter, sir.
Okay. Now, okay. What medications patient is taking?
Patient is on carbimazole 5 mg BD, sir, and propranolol 40 mg BD, sir.
Okay. Now, with relation to these drugs,
yes, sir.
Can you tell about which thyroid synthesis pathway, right?
Yes, sir.
Yes, sir.
I'm not asking you the thyroid synthesis per se,
Yes,
but
sir.
I want you to tell me various drugs that act at various stages of the pathway.
Okay, sir. So mainly four drugs can be classified as acting on 4 different steps, sir. First, we can have synthesis inhibitors, which stop the synthesis of thyroid hormones. Then we can have drugs which act on the release and storage. Then we can have, we can also act the drugs which act on the peripheral tissues, sir.
Yeah. Peripheral conversion.
Conversion
Yes,
of
sir.
T4 to T3, sir.
So what are the drugs that prevent peripheral conversion?
Propranolol prevents, sir.
First synthesis, sir, we can
Yes,
have.
sir is asking for peripheral conversion will be propranolol and glucocorticoids.
Propranolol, sir, IV propranolol prevents the peripheral conversion of T4 to T3, sir.
Okay, fine.
Beta blockers can be a choice for that, sir.
Yeah. Then what about synthesis?
Synthesis, mainly we will go for propyl thiouracil or carbimazole, sir.
Okay. What about these thiocyanates and perchlorates?
Thiocyanates and perchlorates. I am thiopentone, sir.
That is still in for little early.
And stuff, synthesis of new thyroid hormones, sir.
Okay, so okay, that is
in iodine therapy will be given for 14 days, sir. If this even after prolonging it more than 14 days, this will lead into
further causes features of
features
thyrotoxicosis.
And this is actually iodine induced hyperthyroidism, which is also
called as thyroid escape
and Jod-Basedow phenomenon.
Jod-Basedow phenomenon.
Okay, done. Okay, fine. Then that is about those two. Okay. What other positive findings in this history?
But this patient had
so patient
weight loss in spite of normal appetite, sir.
Weight loss in spite of normal appetite, sir, and also has palpitations, tremors, pressure symptoms of difficulty in deglutition, as well as dyspnea on lying down. Sorry, breathing difficulty on lying down.
And 1 month it has been there, sir, deglutition, and for the past 1 month she has the problem for dyspnea also, sir. Okay, fine. Now proceed with the further case presentation.
Okay, sir. Not able to. Okay. So we're going into general examination, sir. Patient is conscious, oriented to time, place, and person, comfortable and cooperative, moderately built and nourished, afebrile on touch. Height is 144 centimeter, weight is 61 kgs, BMI 29.4, METS is greater than 4. No pallor, icteric cyanosis, clubbing, pedal edema, peripheral significant lymphadenopathy. Eyes is normal. Vitals, pulse rate 1 or 2 per minute, regular in rhythm, normal in volume, no specific character, no radial or radiofemoral delay, felt in all accessible peripheral vessels. BP is 120/90, measured in the left upper limb with patient in sitting posture. Respiratory rate 18 per minute, thoraco-abdominal. SpO2 is 99% at room air and temperature is 98.3. So we go into the local examination, sir.
Inspection, sir. The patient was examined in sitting position. The trachea was appearing to be mildly deviated towards right side. The swelling was present in the anterior aspect of the neck in the region of thyroid, to the size of 4 into 3 centimeter on inspection, which was extending to the left lobe of the thyroid gland, sir. The swelling was irregular on the inspection. Surface appears to be smooth. Skin over the swelling appears to be normal. Lower border was not visible on inspection. Swelling was moving with deglutition. Any muscle weak?
Sir?
Yes, sir.
Have you ruled out any muscle weakness with the patient?
Yes, sir. She didn't have any complaints of muscle weakness and pain, but she did have tremors on outstretched hands, sir.
Okay. So in this context, can you just tell me what is men syndromes?
So men syndrome is basically there is men type 1 and men type 2, sir. Men type 2, there is men 2A and 2B. Men type 1, we have pituitary adenomas. There might be pituitary adenomas, pancreatic tumors, and parathyroid hyperplasia, sir. Here in men type 1, there is no involvement of thyroid or adrenal gland. In men type 2, sir, we have 2A and 2B. In both these, there is thyroid involvement. You have medullary carcinoma of thyroid and pheochromocytoma. In 2A, we also have papillary thyroid cancers, and in 2B, we have neuromas which may form, sir.
Okay. Okay, proceed with your inspection findings and further.
Yes, sir. Yes, inspection. Patient was examined in sitting position. Trachea was appearing to be mildly deviated towards the right side. The swelling was in the anterior aspect of the neck, which appears to be in the size of 4 into 3 centimeter, which was extending to the left lobe of the thyroid gland, sir. The swelling was irregular in appearance and surface appears to be smooth. Skin over the swelling was normal. Lower border was not visible. Swelling was moving with the decretation, but did not move with protrusion of tongue. No scar, sinuses, or dilated veins, visible pulsations were present in the neck. And on inspection, Pemberton sign was checked and it was positive for the patient, sir.
What is the meaning?
Pemberton sign is we checked, we asked the patient to raise the hand up above the head, close to the ears, and we will be looking for features such as engorgement of veins present in the upper part of the thorax and nails, and central cyanosis will be there, and blushing of facial.
It's characteristic of retrosternal extension of thyroid swelling, sir.
So this was positive for the patient, sir.
But the thyroid swelling is hardly only 4 into 3 centimeters, correct?
Sir, on inspection
it appears to be 4 into 3, sir, but it was different in on palpation. It was different, and then CT report also we have it was showed that.
Okay,
it was a large swelling, sir, with retrosternal extension behind the left lobe, sir, from downwards.
Okay, what are the findings in palpation and other things? Yeah, palpation, please tell.
Yes, sir.
Sir, palpation. In palpation, no warmth or no tenderness were there. Trachea was deviated to right mildly, and Kocher's test was negative, sir. And nodular, the swelling was nodular, and size was 5 into 3 centimeter. Palpated over the anterior aspect of the neck region with thyroid extending to the left side, and shape was irregular. And as borders were checked, the upper border extending 1 centimeter from hyoid bone and lower border was not palpable. Surface was nodular, firm in consistency, and carotid pulsation felt against the upper border of the thyroid cartilage, equal intensities on both sides. Berry sign was negative. There was no palpable thrill. No other swelling were present, sir.
Okay, what is this Coccus test and Berry sign?
Sir.
So Kocher's test is to test whether there is tracheal involvement, tracheal compression, or there is presence of tracheomalacia, sir. So basically, when we push, we make the patient.
Are you sure?
Sorry, sir.
Tracheomalacia, are you sure?
Yes, sir. Involvement.
Sir, any compression in trachea, we will be checking about. We'll be using Kocher's test in order to check about that any compression is present in the tracheal region.
Weakness of the tracheal rings, sir.
So we'll be pushing. Yes, sir.
Sir.
I mean, how do you do that?
So we make the patient sit from the front. We try to push both the lobes towards the midline.
No, we'll be pushing that one lobe into that medially.
Both the lobes we will be pushing towards the midline, sir. So in case there is tracheal involvement and weakness of the tracheal rings, there will be collapse of the trachea and stridor will be presenting, sir. So that case, Kocher's test is positive, sir. But in this case, there is deviation of trachea, but there is no tracheal collapse, sir.
So what about your Berry sign?
Berry sign is more significant of a malignant swelling, sir.
Carotid artery, and it will be present in the carotid sheath, and in term of involvement of carotid sheath, that carotid pulsation will be negative for those kind of patients, and that shows Berry sign positive. If carotid pulsations are not felt, it shows Berry sign is positive. And for this patient, carotid pulsation was felt against the upper border of thyroid culture, equally intensity on both sides, sir. So Berry sign was negative for this patient, sir, as Kocher's test also.
Okay, so getting below the swelling.
So we were not able to get below the swelling, so the lower border was not palpable.
As the upper border was extending 1 centimeter from the hyoid bone, lower border was not palpable, sir. So all the inspectory findings were confirmed, other than the size, which was different, sir.
Okay, fine. Then proceed with further.
Then percussion was done, which showed retrosternal dullness was there, and on auscultation, carotid brood was checked and it wasn't there, sir. and examination of lymph node was done. No palpable lymph node present in the neck region, sir. This was the local examination, sir.
Okay, next.
Systemic examination, respiratory system, normal vesicular breath sounds, bilateral and equal. Sir?
Sir?
Any positive findings in systemic
No,
examination?
sir.
No, sir.
Systemic examination was
CNS showed fine tremors only in
Tremors.
outstretched hands, sir. Higher mental functions were normal,
Normal.
sir.
Okay, what is your airway examination?
Airway examination, there was positive findings, sir. There was
Trachea deviated to the right, sir. Mouth opening was adequate, but there was no restricted neck movement present, sir. Patient was not able to flex the neck, while feeling discomfort on flexing the neck, sir.
because of the thyroid swelling.
Thyroid swelling. So tracheal deviation to the right and neck movement restriction
neck
were the two
movements,
positive
sir.
findings in the airway examination, sir.
It's 4 into 3 centimeters.
So 4 into 3 was an inspection, sir. On palpation, it was
Approximately 6 into 5 centimeters, sir. The swelling was.
on inspection it was 4 into 3 centimeters, sir. On palpation, it was 6 into 3 centimeters, sir.
Okay, fine. Next. What is the diagnosis?
After airway examination,
We go forward with the investigation, sir, for the patient.
Coming to the diagnosis, what is your diagnosis?
So the diagnosis was a case of multinodular goiter.
sir, a 55-year-old female present with thyroid swelling in the anterior aspect of the neck for the past 4 years, associated with weight loss, tremors, palpitation, and difficulty in breathing in supine position, and difficulty in deglutition for solid food, which shows suggestion of retrosternal extension of swelling, is on treatment of top carbimazole 5 mg BD and propranolol 40 mg BD, sir.
So it was basically a case of
So
multinodular goiter
sir.
with features of hyperthyroidism, and also retrosternal extension was there, sir. Posted for subtotal thyroidectomy.
Okay. Say
So the
this
investigation,
is-
sir. Yes, sir.
Now, with regard to the investigations now,
Yes, sir.
you need to categorize and tell me the investigations for the diagnosis and investigations for anesthesia and any other investigations with regard to the pathophysiology and complications of the diagnosis.
Okay.
So can you just categorize in this way and tell me?
Yes, sir.
So first we will be looking for the anemia, sir.
So patient.
Diagnosis first.
Sir?
See, basically, in the history,
Yes, sir.
you will come to some diagnosis.
Yes, sir.
I'm just saying for any case presentation, you remember, like from history, you come to some diagnosis,
Yes, sir.
and from that you are trying to rule out in the history itself various what I meant to say complications and pathophysiology associated with your diagnosis.
Yes, sir.
You had already done.
Yes.
Then
sir.
what you got from the history diagnosis, you try to confirm it with your clinical examination.
Yes,
Yes,
sir.
sir.
And your final clinical examination diagnosis, again you will confirm with your investigation.
Investigations.
Yes, sir.
So investigations for the diagnosis of this thyroid swelling and other things, what all you have done to confirm?
Sir, actually, the thyroid patients will be more like hematologically they'll be having anemia and thrombocytopenia also, sir. And for this patient, sir?
Diagnosis.
So diagnosis mainly we will have TFT and the radiological findings, sir. The
TFT, what are the findings?
TFT, right before the patient, and since the patient is on anti-thyroid drugs, she was taken up under euthyroid state only, sir. Right now she is euthyroid.
So when she came to us, sir, yes, sir.
Euthyroid state, sir.
Okay, then radiological findings.
Radiological findings, chest X-ray, it shows a superior mediastinal opacity, sir, causing mild tracheal deviation to right. The superior margin was untraceable. Lateral neck X-ray and
AP
AP
and
view, they show tracheal and esophageal compression and there is narrowing, and that the mass fades out inferiorly. Then USG for an anechoic cystic lesion, maximum size of one nodule being 2 into 2 centimeters, sir. And naturally, since we suspected retrosternal extension, we did a CT, sir.
And CT showed a symmetric, yes, sir.
Okay, coming to the CT findings.
Yes, sir.
Based on your CT findings, how do you grade retrosternal extension?
Sir, retrosternal extension might be having showing features of SVC obstruction in case of severe.
Using the CT,
Yes, sir.
how do you grade retrosternal extension?
Sir, I'm not sure about that, sir.
Yes, sir.
I will read about
I'll read
it.
about it.
I'll be online. You can just Google it out.
Yes, sir.
Retrosternal extension, CT grading.
Yes, sir. A minute, sir. Extension. Sir, there are three grades, sir. Grade 1, 2, 3. Grade 1, the goiter is Hello, sir.
Yeah.
Sir, can you hear us, sir?
Yeah.
Yes, sir. Grade 1, the goiter is located above the aortic arch.
Yeah.
Grade 2, the goiter extends from the aortic arch to the pericardium. Grade 3, the goiter extends below the right atrium.
Okay, now this case, what is it?
Sir, this case, which extends?
Extends below the thoracic inlet, sir, and above the aortic arch.
Above the aortic arch, so it is grade 1, sir.
Is it grade 1?
Yes,
Okay,
sir.
fine. Okay, now this is about diagnosis.
Yes, sir.
Yes, sir.
With regard to your airway management, you already have done. So this compression, what you are saying is at what level?
Sorry,
From
sir.
your radiological findings,
Yes,
you have done
sir.
this. No.
Yes, sir.
This compression is at what level?
Superior mediastinal level only, sir, above the aortic arch.
Okay. Right from vocal cords to down, no? Is there any compression?
Sir, compression, patient has dysphagia.
Tracheal and esophageal
Compression is
are
there, sir. Dyspnea,
Okay, what is the
dysphagia.
narrowest area in the entire airway?
Sorry, sir.
What is the narrowest area? What is the vertebral level at which there is the narrowest area?
Glottis, sir.
Glottis.
And here.
Here,
This
sir,
thoracic.
around C6, sir.
C5, C6, sir.
Which one? I'm not saying. No. Your CT finding.
Yes, sir.
At what level is the narrowest area? That I'm asking.
Intrathoracic part, sir.
Otherwise, upper part is normal.
No, sir. There is narrowing from the upper to the lower part, sir. Mostly in the above the thoracic inlet, there is compression, sir.
Now, what I meant to say is, when you plan for anesthesia, you need to clearly know at what level there is a narrowest compression and how long is the compression. Whether you can go, everything we need to plan it up, right?
Yes, sir. Mostly at the level of trachea, sir.
Mild external compression and displacement of
Tracheal
level, sir. At tracheal level, that airway region, that it is narrowing, sir. Narrowing is present, sir.
Okay, this is about the airway thing.
Yes, sir.
Yes,
in
Now,
CT.
for anesthesia, what are the investigations you have done?
Sir, we have checked whether the patient is in euthyroid state, sir. So TSH, free T4, free T3 was done.
That's the other investigations. Anesthesia.
Sir,
You asked for
ECG and echo was done in order to look for any arrhythmias present. And echo was done in order to check EF of the patient.
Okay, what about hemoglobin?
Yes, sir. Hemoglobin showed 11.3 gram per deciliter, sir.
Why? Any relation with antithyroid drugs?
Sir,
Sir, it will cause anemia and agranulocytosis, sir. So, hemoglobin and platelet, yes, sir.
Why do you do indirect laryngoscopy?
Sir, in order to look medico-legal aspect, we have to check for ideal because vocal cord
mobility we are checking.
Yes, sir.
Okay, that's all, no investigations?
Yes, sir.
Yes,
Yes, sir. Then normal RFT and sugars were checked, electrolytes were checked because not to look. Other than that, other findings are normal, sir, for the patient.
Yes, sir.
Okay, now this patient is post subtotal thyroidectomy, you
Yes, sir.
told.
Yes, sir.
Okay, how do you proceed with anesthesia?
Sir?
How do we proceed, sir? I'll start it from intra or
Sir,
pre-op,
pre-medication, sir, we have to check.
we will start with pre-medication. So pre-induction medications we will be giving for the patient after shifting to OT.
No, I'm talking about night before surgery and morning of surgery.
Sir, night before surgery, we will be going to the ward bedside of the patient. We will be doing our PAC confirmation, sir. Whatever findings in PAC, whether it is confirmed bedside for the patient.
And morning on the day of.
Then we will be asking patient consent is very important, sir, for this case. Then we will be explaining the patient regarding the consent, and then we will be if the necessary, we will be reserving the blood products, sir. Then aspiration prophylaxis, anxiolytics can be given for the patient, sir.
Sir, if on high risk any consent is needed, also we have to explain those high risk consent because post-op ventilatory support might be needed because so that we have to explain that to the patient also regarding that, sir. So,
yeah, fine. What drugs you give in the night and what drugs you give in the morning? So
we can give anxiolytics.
Anxiolytics we have to give diazepam. We can
midazolam previous night, sir. Morning of surgery, we'll give aspiration prophylaxis, probably injection pantoprazole, sir.
For anxiolytic, we can give diazepam if needed, sir.
So, what do you give in your institute?
So we give midas.
Midas, sir. Before the night of surgery, we give midas, sir.
Midas injection you give? No,
sir. Actually, in our setup, we normally see the age group, sir. And we see the current situation of the patient, whether this needed for the patient, is he or she is very anxious or not. And age also we look into it because OSA patient also we can't, we'll consider for each patient, and if needed we'll use or else we won't, sir. In the morning
yes,
we might give diet.
My doubt is,
yes, sir.
For all patients, what do you give?
Benzodiazepine, sir. We'll give benzodiazepine.
Normal elective cases, we write Alprax, sir.
Alprazolam.
Okay, fine.
So Alprax will be given if patient age is more. Yes, sir.
So which drugs you want them to continue and which we want them to discontinue?
Anti-thyroid drugs, all the drugs we will be continuing, sir.
On the morning of surgery also will be continuing, sir. And propranolol, if heart rate is...
we'll be continuing beta blockers also.
Beta blockers will be continuing and it should be maintained less than 90. So propranolol also will be continued, sir.
Okay, you have shifted the patient to the theater.
Okay.
So now you just tell me.
Yes,
okay,
sir.
Monitors what you are going to connect. Classify them into pre-induction monitors and post-induction monitors.
Pre-induction monitors will be connecting saturation probe. Then we'll be connecting non-invasive blood pressure monitoring. And we'll be measuring ECG. We'll be connecting ECG and we'll be measuring heart rate through ECG and pulse rate through SpO2. And normal by yes, sir. We'll be seeing for that blood volume of pulse also, which will be profound. Bounding pulse might be there. So
post-induction.
So post-induction will be connecting ETCO2 will be additional monitoring. After putting the ET tube, will be connecting ETCO2 and additionally
yes, sir.
Yes, sir.
What is the relevance of
neuromuscular? Yes, sir. Sir.
What is the relevance of ETCO2 in this?
Sir, hyperventilation should be avoided.
Hyperventilation should be avoided, sir, for this patient. So normal ventilation is preferred.
Okay.
So controlled ventilation and ETCO2 should be in the normal.
I mean, what all the ETCO2 will give you an idea in this case.
Sir, in case the patient goes for any thyroid storm or something, there will be sharp increase in ETCO2, sir.
Okay, fine.
If it is a
Okay,
grave
what, okay, what other monitors you are going to connect?
Sir, temperature monitoring also we will be doing, sir,
Yes, sir.
because that is very important. Hypothermia should be avoided.
No, not to avoid. If
Yes.
patient lands hyperthyroidism.
Hyperthermia also, sir. Yes, sir. So we have to
Yeah.
monitor temperatures.
Okay.
Yes.
Then, okay. So, how do you induce? How do you intubate?
So induction.
Induction will be as the
IV
patient is more known for heart rate will
IV
be
and inhalational agents we will use, sir.
if difficult, yes, sir. IV and inhalation also, sir.
First, we will be pre-oxygenating. We'll do mask ventilation, sir.
And
Then we will be inducing with IV and inhalational agents. IV we will be we use thiopentol and propofol,
propofol
sir.
for yes, sir.
Means propofol.
Which one you use this case? I'm
Sir?
asking you how to describe anesthesia for this case.
So propofol was used, sir.
Propofol was used, sir, for this patient.
Okay. What about you are saying retrosternal extension? What precautions you have taken then?
So
We had
during
a
mask ventilation to aid in proper oxygenation, we will hold up the swelling. Someone will assist us holding the swelling up so that the airway is clear and there is proper ventilation, sir.
until ET tube is placed, that thyroid gland will be holded up, sir. So that yes, sir.
You are saying the gland even substernally itself it is compressed. No, how do you handle that situation?
Patient positioning, sir.
No, you are saying retrosternal extension, correct?
Yes, sir.
And you are saying there's a compression there.
Yes, sir.
Then inducing
We can use
not
FOB and awake intubation, sir.
yeah. The choice you are saying tracheal compression, deviation, and retrosternal extension.
Yes, sir.
Yes, sir.
FOB should be kept ready, sir.
Not ready. You need to use a fiber optic.
Okay,
Yes,
sir.
sir.
Because the way you are saying, I have not seen the case, but the way you are
Yes, sir.
presenting.
Yes, sir.
Okay, after putting the tube and the case is going on,
Yes, sir.
in between temperature rises and ETCO2 goes up. What is your diagnosis and how do you manage?
It could be a case
Sir,
where thyroid storm is developing, sir.
so malignant hyperthermia also will show, yes, sir.
Thyroid storms mainly, it could be leading to thyroid storm because the patient is a hyperthyroid patient. Symptoms of thyroid storm will be, we will be watching out for hyperthermia, excessive sweating in the patient, hypertension.
And how do you treat?
So, first line, we will be giving anti-thyroid drugs, sir, like propyl thiouracil, we will give. Then iodine. We will be giving sodium epodate instead of iodine, sir. We will be giving cold saline flushes and we'll also be using cold saline blankets and we'll try to bring down the temperature, sir. Then for if there is acidosis, we'll be using sodium bicarbonate, sir, to correct the levels.
Okay, beta blocker?
Beta blockers
Yes, sir.
also, IV propranolol can be used, sir. 2 to 4 mg IV can be given, sir.
If infusion is needed, esmolol also can be used.
0.5 mg per
0.5 mg per kg.
Okay. You want to give iodine first or your...
No, sir. We will give ATT for anti-thyroid drugs
Anti-thyroid
first.
drugs will
And
be
in
given
emergency
first.
purposes, after giving anti-thyroid drugs, 1 hour later we can.
Anti-thyroid drugs will be given, sir. Then post 1 hour of that, we will give sodium iodate, sir.
Always that iodine should be preceded after anti-thyroid drugs given, sir. It should not be given first, or else it might lead to thyrotoxicosis if it acts alone, sir.
Okay, now you have come to the end of surgery.
Yes, sir.
Say, imagine that there is a huge goiter.
Yes, sir.
And you are suspecting trichomalacia.
Yes, sir.
What tests you do and how do you extubate?
During
So
extubation,
tracheomalacia, if we are expecting, we will do the cuff leak test, sir, majorly.
What is the
sir, the cuff will be actually first the tidal volume will be noted down, sir. That set tidal volume, that actual tidal volume of the patient will be noted on the venti. Then the cuff will be removed, and we'll be looking for any increase or decrease in tidal volume changes, or we can if there is airway edema present, there won't be any.
if the complete test is positive?
Yes,
Yes,
sir.
sir.
How do you extubate?
If cuff leak test is positive, then there is tracheomalacia.
We actually we'll be using FOB, and with the FOB we'll try for extubation with the FOB. If there is airway collapse there, and right before that we have to use the FOB and the ET tube together, and we have to proceed past the bevel should be past the tracheal whatever the compression is, and that should
Suppose
be.
that you don't have FOB, what you will do?
Sir, we can use.
Sir, delayed extubation we can plan, sir. If at all, if you are questionable airway, we can delay.
Sir,
the
we can use FOB. If it is not, we can use video laryngoscopy, sir.
Or else we
That
can
is-
secure the airway with a catheter or a bougie, and then we can try for extubation. If
Airway
not possible,
exchanger can be used.
if not
sir.
possible, we can use the bougie to re-intubate the patient, sir.
Yeah, airway exchange catheter, you need to use it.
Yes,
Okay.
sir. Airway exchanger can be used, sir.
Okay, this case you shifted to post-operative ward and suddenly patient is breathless. What is your diagnosis and how do you manage? What are the
Hematoma might have been found for the patient.
Hematoma is not there.
Sir?
Hematoma is not there. What else?
Hematoma is not there, sir.
Sir, any nerve injury, sir?
Okay, with regard to the nerve injuries,
Yes, sir.
which conditions you get aphonia? Which conditions you get what I meant to say?
Stridor.
Yeah,
Sir, aphonia, we will get in partial palsy, sir. If it is both vocal cords, sir, aphonia will be
Sir, complete if there is
complete both sides.
if
bilateral.
the vocal cords are in a normal position, they are not able to close.
So bilateral complete
recurrent laryngeal nerve
palsy,
palsy,
we will get
aphonia, sir.
Aphonia, sir.
And partial
Stridor,
then
bilateral partial palsy, we will get stridor, sir, chiefly.
not partial, bilateral, incomplete.
Yes,
incomplete, we will get stridor, sir.
Okay, other than that, what other complications you can expect post-operatively?
Sir, hypocalcemia might have after 36 hours we have initially 6 hours post-op we have to check for calcium, and later 24 hours we have to check for calcium because hypocalcemia might have been.
It will take time, correct?
Sir?
Yes, sir.
Yes,
That will take time,
sir.
Okay, what other complications?
Any edema, sir, laryngeal edema?
Edema or hematoma might also form.
Hematoma is not.
In ward, after shifting the patient, any hematomas might have been formed. So we have to be ready for that also. We have to inform the surgeon about it, and we have to remove that alternative suture, sir. And that will then the surgeon will be looking for any bleeding, and they have to clear that hematoma, sir.
Yes, sir.
Okay.
Yes, sir.
Then this. Okay, fine. Now about this thyroid case, post-operative complications. What about the post-op analgesia?
Post-op analgesia, we can give.
Sir,
we can even give blocks, sir, for pain relief. Superficial cervical plexus blocks
block
can be given.
can be given, sir. And unilateral deep cervical plexus block can be used.
Non-steroidal anti-inflammatory drugs, sir.
And narcotics.
Narcotics, yes,
yes,
sir.
sir.
Okay, then what? That intubation, what type of tube you have used?
We used
Flexometallic, sir.
flexometallic, sir.
Okay. What are the advantages and disadvantages of flexometallic?
Flexometallic, when we use, sir, we can for
We
head
can-
and
for
neck
position- for positioning of-
positioning, and they'll not. We need not have worry about kinking of the tube will not be there, sir.
Okay, disadvantage?
It might slip out, and there may be increased chances of auto extubation, sir.
As
Yeah.
patient, yes, sir.
That can happen with any tube.
Any tube,
That's
yes.
not. What is the main disadvantage?
I'm not
Sir,
sure.
we'll see.
Not
see
sure,
this.
sir.
See, when you put flexum, see, always people say while shifting out, you change them to normal tube and send it out. No.
Yes,
Yes,
sir.
sir.
Why
Yes,
they
sir.
say?
Sir, edema, it might cause more
Edema. The thing is, if a patient bites, no,
Yes, sir. There will be
it is a permanent constriction.
Yes, sir.
Okay, so how do you know intraoperatively that patient has bitten?
Okay, new tube. Okay, sir.
And how do you know that patient has bitten?
T peak will increase, sir.
Not what do you say?
T peak.
Sir, airway pressure will be
increase.
changing.
Pressure will increase. You are
Yes,
right.
sir.
Yes, sir.
So that's what you need to monitor.
Yes, sir.
Okay. So that is the disadvantage of the flexometallic tube.
Okay, sir.
Okay.
Okay.
Yes, sir.
Then during the position
Yes,
for
sir.
intubation,
Yes, sir.
we forgot to discuss was the position of the patient
Yes,
Yes,
sir.
sir.
for the surgery.
Yes, sir.
Sir, actually,
Why
yes,
do you
sir.
head up?
Yes,
25
sir.
degree-
25-degree head-up position will be given, sir. Patient will have neck extended and occiput stabilized with the ring.
Maximal neck extension with an occiput stabilized to the ring
Okay,
And
and
there will be a sandbag below the
interscapular
shoulders.
area, sandbag should be placed, sir.
Okay, what are the plus and minus of this position?
Disadvantages, this can cause hypotension, sir, mainly for the
Sir,
patient.
and it might auto remove.
Air embolism
The
and
tube might remove itself because
auto extubation.
trachea will be more in extension 2.5 by 2.5 centimeter will be more on complete neck extension. So tube might slip out automatically, sir. So that is a negative point in this position.
Hypotension and even air embolism, sir.
Okay. So to prevent hypotension, you can raise the lower limb.
Yes, sir.
Okay. So only thing is before extubation, talk to the surgeon how good are the tracheal rings.
Yes.
And with regard to the laryngeal now policy involvement, what he does it. Okay.
Okay. Yes, sir.
Okay, these are the common questions that are asked, or in addition, they will ask you about anatomy of thyroid gland and the nerve supply and arterial supply also, they may ask.
Okay,
Yes,
sir.
They
Okay, sir.
and they may not restrict to hyperthyroidism itself. They may ask about to give a scenario about hypothyroidism and mixed edema, and they may ask you how you are going to manage.
Okay,
Yes,
sir.
sir.
Yes, sir.
Okay, then, yeah, it is a